QRS complexes. And the presenter is Dr. HOLZMEISTER from Zurich, Switzerland.
Thank you very much. Good morning. The EchoCRT study was an investigator-initiated trial led by the University of Zurich from my co-principal investigator, Dr. Rashidskar, and U.S. co-principal investigator, Dr. Abraham. Declaration of interest. Heart failure affects more than 23 million people worldwide, with increasing prevalence and frequent hospitalization is a major cost to healthcare and patients. We know, and it's class 1 level of evidence, that CRT reduces morbidity and mortality in heart failure patients with a wide QRS complex. Many heart failure patients with a relatively narrow QRS, which is below 130 milliseconds, have mechanical dyssynchrony, described by echocardiography, a potential target for cardiac resynchronization therapy. Moreover, a European CRT survey published recently showed that a substantial number of heart failure patients received already CRT devices with a relatively narrow QRS duration. 9% in patients with a normal QRS complex, this is below 120 milliseconds, and 10% of patients with a QRS duration between 120 and 129. This created equipoise and the demand of a definite outcome trial, which EchoCRT was designed for. To elevate this, we designed a morbidity and mortality trial adding CRT on top of standard pharmacological therapy and an ICD in patients with impaired left ventricular function equal or lower below 35% and a narrow QRS complex below 130 milliseconds and mechanical dyssynchrony. Again, EchoCRT was an investigator-initiated prospective international multi-center trial led by, overseen by the FDA, and it was, there were two groups. There was a CRT group where patients were programmed to receiving CRT, and there was a control group. These patients also received the CRT-D device, and these patients were programmed to an ICD-only function. So it's a one-to-one design. Here are the results. EchoCRT did not reach its primary outcome since the trial was also stopped for futility with a potential to harm. The hazard ratio we could report here is 1.2 and did not reach statistical significance, of course, with a p-value of 0.15. Of course, we looked at these subgroups available. I'm just showing here because of the shortness of time. The first plot overview, there was no signal of any benefit of CRT in narrow QRS patients in these subgroups, and we can discuss this later in more detail. Per protocol specific outcome, there was a surprising finding, but we have to be very careful and caution to interpret it, since the trial was stopped for futility and there are relatively small amounts of events. However, at the end of the study, there was a nominal increase of mortality, all-cause mortality, in the CRT group, 26 deaths in the control group compared to 45 deaths in the CRT group, which reached a nominal significance of 0.02. Per protocol pre-specified cardiovascular mortality was 17 versus 37, which reached a nominal significance at 0.004. In summary, EchoCRT demonstrates no benefit of CRT in heart failure patients with a relatively normal QRS duration on recommended pharmacological therapy and in ICD. This is perceived from the executive committee as a definitive study in this regards. We think that these, on our results, provide important timely guidance to physicians about how to appropriately allocate resources to the right patient. And again, due to the early termination of the trial, abbreviated follow-up duration, and a relatively small number of events, a firm conclusion about mortality cannot be reached. And EKG remains the best approach for selecting patients for CRT in the future. Thank you.
Thank you very much. Are there any questions? Please, the mic.
Mitchell Zola, Cardiology News. Did one of your sub-analyses look at patients below and above 120 milliseconds?
Yes, we did, but we had very few patients in the group between 120 and 130, and this did not reach any significance level here.
So what implications do you think your findings have for patients in the 120 to 130 range who would be candidates to get it under guidelines and yet part of a trial that's showing harm?
I think it's not too up. We just report the data here, and we had to report, of course, the totality, meaning below 130 milliseconds. But if you look at the forest group, the number of events and the number of patients enrolled in the trial between 120 and 130 was small.
Which line is that, please?
This is here, and this is also discussed in an editorial of the New England Journal of Medicine, which just is now online, and I would refer to that.
Well, I know the editorial doesn't suggest a problem 120 to 130, but I'm asking your opinion.
I, again, can only say this is the data we have in a relatively small numbers between 120 and 130, not to conclude here.
Please.
Steve Stiles, theheart.org. Do you have any insights about the mechanism of the increased risk in the CRT group? I noticed that both all-cause and cardiovascular mortality were increased, but hospitalizations weren't.
Exactly.
Or not, but they all had ICDs.
They all had ICDs, and we will show this in the session later, the data in more detail. We looked very carefully to understand the mechanism. We discussed this also in the paper. And at the moment, we saw an increase in sudden cardiac death. However, again, small numbers and study stop for futility, but we will show this later.
There are further questions? There's one more question here.
The statistic you showed from 2008 or so that in Europe 9% of patients were getting CRT with a duration of under 120. Do you think it's been maintained at roughly that level or even increased? And so would the implication of your study be that all those patients should not be getting these devices?
Well, I have no data at the moment to tell you the exact number of patients on CRT in Europe at the moment. And again, we just report the data now, and it's up to the guideline committees to give any further recommendations then.
Okay, thank you so much. So, further questions?